Most of the probiotics on the drugstore shelf are dying long before they reach your gut. The label says 50 billion CFU, pretty number, but that count is the snapshot at manufacture, not what's left when you swallow the capsule. By the time the bottle sits on a warm shelf for 6 months and lands on your kitchen counter, a lot of those bacteria are gone. The real question isn't how many, it's which strain, and whether any of them are still alive. Start with the definition the research community actually uses. The 2014 consensus statement in Nature Reviews Gastroenterology, the one assembled by the International Scientific Association for Probiotics and Prebiotics, gave us the working definition. Probiotics are live microorganisms that, when administered in adequate amounts, confer a health benefit on the host. 3 words in there matter: live, adequate, and specific. The consensus is clear that strain identity is not a detail, it's the whole point. Generic acidophilus on a label means almost nothing. Different strains of the same species behave like different drugs. McFarland and colleagues in 2018 pooled 228 trials in Frontiers in Medicine. The conclusion? Probiotic efficacy is both strain-specific and disease-specific. Lactobacillus rhamnosus GG works for antibiotic-associated diarrhea. A different Lactobacillus rhamnosus strain may do nothing for the same condition. Same species, different organism, different result. The strain on the label is the variable, not the CFU number, not the brand. Here's how that plays out in the real world. The PLACIDE trial. Allen and colleagues in The Lancet in 2013. Nearly 3,000 older inpatients on antibiotics. They got a Lactobacillus acidophilus plus Bifidobacterium blend. A reasonable-looking product. The result? No effect. The probiotic group had 10.8% antibiotic-associated diarrhea. Placebo had 10.4%, identical. People look at PLACIDE and conclude probiotics don't work. The right conclusion is narrower. The specific strains in that specific blend didn't work for that condition in those patients. Strain specificity cuts both ways. Switch to the strain that does have evidence for the same problem. Shaevska's 2015 meta-analysis in Alimentary Pharmacology and Therapeutics pooled 12 trials on Lactobacillus rhamnosus GG. Antibiotic-associated diarrhea risk dropped from 22.4% to 12.3%, almost a halving. Same genus, different strain identity, wildly different outcome. Grab a random probiotic off the shelf during an antibiotic course, and you may have grabbed PLACIDE. Grab LGG, and the research is on your side. Now the CFU problem. The label says some big number, 50 billion, 100 billion. The industry best practice from the Council for Responsible Nutrition is clear. CFU counts should reflect what's in the bottle at the end of shelf life, not what was packed at the factory. But many products use an asterisk and a footnote that says CFU at time of manufacture. Translation, by the expiration date, there's no promise about how many bacteria are still alive. Markabal and colleagues audited 14 commercial probiotic products in the Journal of Pediatric Gastroenterology in 2008. Many contained extra species not on the label. Others were missing species that were on the label. Survival to the gut is the other half. Probiotics have to walk through stomach acid, bile, and pancreatic enzymes before they reach the colon. Strains differ enormously in how many survive the trip. Yeast-based probiotics like Saccharomyces boulardii are inherently acid-tolerant. Many Lactobacillus and Bifidobacterium strains aren't, which is why those products often need refrigeration, delayed release capsules, or both. If your shelf-stable probiotic spent 6 months on a warm pharmacy shelf with no enterit protection, the math is brutal. So the fix isn't bigger numbers on the label. The fix is the right strain in a form that actually gets into your gut alive. That's where we're going next. Here's the protocol the research actually backs. Step 1. Match the strain to the condition, not the brand to the marketing. If you're starting an antibiotic course, the strain with the strongest meta-analysis support for antibiotic-associated diarrhea in healthy adults is Lactobacillus rhamnosus GG, sometimes labeled LGG. That's Shaevska 2015. If your concern is Clostridium difficile prevention while on broad-spectrum antibiotics in the hospital, the Cochrane review by Goldenberg in 2017 pooled 39 trials. CDI rates fell from 4% in placebo to 1.5% on probiotics, with Saccharomyces boulardii and certain lactobacillus blends carrying the strongest signal. C. diff is a medical scenario. Talk to your doctor before adding anything alongside hospital antibiotics. For mild to moderately active ulcerative colitis, the strain blend with the strongest randomized evidence is the 8-strain formulation originally sold as VSL3 and now distributed as the DeSimone formulation. Tercy 2010 in the American Journal of Gastroenterology showed reduced disease activity scores added to standard treatment. UC is a gastroenterologist conversation, not a YouTube purchase. Step 2. Read the label like a researcher. Look for the full strain identifier, not just the species. Lactobacillus rhamnosus GG. Saccharomyces boulardii CNCM I-745. Bifidobacterium animalis subspecies lactis BB12. If the label only says probiotic blend with no strain codes, the manufacturer is telling you they don't want you to check. Look for CFU at end of shelf life, not at manufacture. If the asterisk says at time of manufacture, the number doesn't apply by the time you swallow it. Refrigerate where the strain requires it. Most lactobacillus and bifidobacterium products degrade faster at room temperature. Yeast-based S. boulardii is the exception. It's stable on the shelf. Quick note before we go further. This is research, not medical advice. The strains and study numbers come from peer-reviewed trials, not a prescription. Talk to your doctor before adding anything, especially if you take medication or have an ongoing condition. Critically, if you're immunocompromised, on chemotherapy, have a central venous catheter, severe pancreatitis, or are in the ICU on broad-spectrum antibiotics, probiotics carry real risk. Mayer 2023 in Critical Care Medicine reviewed 23,000 ICU patients on probiotics. 86 developed bloodstream infections caused by the very organism in the supplement. Mortality more than doubled in that group. For the average healthy adult on an outpatient antibiotic course, the safety profile is reassuring. For those high-risk situations, the conversation belongs in your doctor's office before any bottle gets opened. Step 3. Honest expectations. Hempel's 2012 JAMA meta-analysis of 82 trials found probiotics cut antibiotic-associated diarrhea risk by about 42% overall. Real fact, but the authors flagged significant heterogeneity. Pooled across everything, probiotics help, but which strain, which dose, which patient drives the variance? A generic acidophilus capsule may do nothing, while the right strain at the right dose for the right condition can almost halve your risk. The pooled number hides the strain story. So, the full picture. Match the strain to the condition. Read the label for the strain code, not just the species. Buy CFU at end of shelf life, not at manufacture. Refrigerate where the strain requires it, and for high-risk medical situations, take it to your doctor first. If you want the gut and insulin sensitivity version of this lesson, the natural compound the research keeps comparing to a major diabetes drug, check out our video on Berberine. The link is in the description below. This is research, not medical advice. Talk to your doctor before changing anything.